Good evening, everybody. I'm here to provide you with the emergency department perspective on COVID-19. And before I begin, I just want to acknowledge we're now 2 years into this pandemic, and it's not lost on me that the tragedy has been quite incredible in terms of what the effects have been on the patients who we've lost, the healthcare providers, and what toll all of the pandemic has had on the healthcare system in general. No relevant disclosures to tell you about with regard to this presentation. So let me talk to you about a patient who's come to the ER. He's 67 years old, unvaccinated due to strong personal beliefs. Omicron is still the dominant variant in the community. He's on he has hypertension, but not taking any medications, a normal BMI. And of course, as we've seen many of these stories, he attended a small gathering 5 days ago and is now coming in with new sore throat and shortness of breath on exertion. He's a bit tachypnic, but the SATs are fine on room air, although he does desaturate with exertion. And we do a lot of exercise testing in the emergency department to see what happens to individuals in terms of their oxygenation when they exert themselves. So does this patient need to come into the hospital? Next slide. Well, there's been a mountain of research developing prediction rules and scoring systems based on large administrative data sets to look at whether we can identify those patients who need to come into the hospital. And one of the tools that has maybe floated to the surface as being the most widely predictive and validated, at least for emergency department use, is something called the SOAR score. It uses just a limited number of criteria. And as you can see from the list here, it relies on the predictors of BMI, saturation, age, respiratory rate, and stroke. And if we think back to our patient, really he scores negative on all of these things, except gets 2 points for being in the 60 to 69 category. So that translates into a relatively low risk of in-hospital death. And to be frank, with the bed pressures that we have in Canada, there is very little chance that this patient is going to get a hospital bed unless there are extenuating circumstances. And there's reason to believe that there's unreliable follow-up or perhaps some other issues that would prevent him from coming back to the hospital if he gets worse. Next slide. So home management, how would we, if we're going to be sending this patient home, what is it that Dr. Mertz just reviewed that might be applicable to the ER setting? And honestly, the answer is that the number of options that we're using through the emergency department are diminishing, especially as we're going into waves where most of the symptomatology is relatively mild for the patients that are well enough to go home. There are a few exceptions, and I'm going to cover those and also focus my presentation very much on the fact that this is such a rapidly changing field. How do you keep on top of the information and know what the latest is in terms of what you should be doing? And you've heard some great resources around the Ontario Science Table. I'm going to cover some others. Next slide. So one of the ones that I think is really invaluable is a collaboration coming out of the Canadian Institute of Health Research and McMaster University, and it's called the COVID19 Recommendations Map. It's free access, it's available to anyone, and what they've done in this project is not only cataloged all of the recommendations that you could possibly imagine relevant to COVID-19, and not just on treatment, but also on issues of masking, isolation, return to work, just the gamut of possible issues that you can think of, and they're all available within this website. Keeping on top of the primary literature is nearly impossible. What you need is a reliable source of information that is unbiased and will tell you what are the best recommendations given in a particular context, because a recommendation in one part of the world may not make sense in another part of the world. Next slide. So this is what the rec map looks like. You can see the incredible number of resources that are available, whether it be on screening, testing, diagnosis, long COVID, which is under the treatment and rehabilitation column. And you can see the matrix there looking at whether you're looking at in-hospital patients, the school setting, healthcare facility, whether the COVID-19 has been confirmed or suspected. And clicking on each of those buttons will bring you to a unique record that I'll show you over on the next slide from these 3,000 recommendations. So here is just the example for sotrovimab, which, by the way, we're using in Alberta. I had an update this morning. The points that have been raised about the difficulty and timing are well appreciated, because despite sotrovimab being available for several weeks and having a very slick system where PCR tests reported to people on their cell phone also advise them to call a number if they meet criteria for receiving this treatment, and the treatment is delivered by EMS teams, paramedics who provide the infusion at home. Despite that, the effort that has gone into that, we've only given out about 1,500 doses since the beginning of 2022 for patients who meet the criteria. So you'll see here on this record that not only do you see the bottom line recommendation on sotrovimab from the Infectious Disease Society of America, but also how they scored in terms of reliability, trustworthiness, and robustness of the guideline. And you see here that in terms of scope, rigor, and editorial independence, their percentage scores were very high. So this is maybe something that you might want to adopt in your setting. Next slide. So we've talked about the sotrovimab, and I've explained to you a little bit about the situation that we're in. So when we don't make these decisions in the emergency department, we have a physician on call for the province who will direct queries related to both Paxlovid and to sotrovimab, and we direct patients to that resource if we meet criteria. But as Dr. Mertz mentioned, many of the patients who test positive will not automatically consider the need for treatment until they get worse. And remember, the COVID pneumonia usually sets in 7-8 days after you're first tested positive and you have your first symptoms, and that's often too late. Next slide. And you know, I have to question, we are using sotrovimab because it's believed to still be the one monoclonal antibody that's still effective in the outpatient setting in the Omicron and BA2 era, but still with the absolute risk in the current wave is certainly less than in the previous Delta wave. And so the number you would need to treat, if you do the calculation, may be much more than it was in previous waves where the risk of hospitalization was much higher. Next slide. So for the patient with significant respiratory symptoms, who's got that terrible hacking cough related to COVID, we will, of course, if it's available, recommend budesonide. So that's essentially the only treatment from what's been discussed so far that we are considering in the emergency department for patients who are going home, especially if there's significant cough to their presentation. Next slide. You have the Ontario Council. I think another useful resource that you might want to consider is coming from Western Canada. The BC COVID Therapeutic Committee not only has created recommendations for what to give in these various contexts, the critically ill, the severely ill, and the mildly ill, but will walk you through what is now becoming really so essential in COVID assessment, which is to look at whether the patient is in a high-risk category and meets criteria for being immunosuppressed, and a very stepwise approach is offered there. Next slide. Next slide. So, you know, I think we are clearly now, based on the wastewater analysis here in Calgary, entering the sixth wave. We are seeing an uptick in presentations. Unfortunately, over the weekend, I had a 95-year-old gentleman who was previously in good health, who presented on day 8 post-COVID positive test with quite severe hypoxemia and pneumonia. And much of my time in the emergency department is spent around the discussion with the family and the patient of goals of care and whether this patient is going to be a candidate for the intensive care unit or not. And we still have quite a situation where the virus is so rampant that about half of the hospitalizations we're seeing still require special isolation rooms, but are not actually directly linked to COVID pneumonia or to patients, especially elderly patients who are demonstrating some change or deterioration or can no longer go home, or who have fallen and happen to be COVID positive, or appendicitis in 30-year-olds who also mentioned that they're having some mild URI symptoms and turn out to test positive for COVID. I think the good news, however, we know that there's been an uptick in BA2 cases in Europe, and this is worrisome and was felt to bode poorly for what's going to happen here over the next few weeks. The good news is, and this is just in the last few days, the case rates are falling in these European countries, which means, of course, that we still are going to get this sixth wave, but hopefully it's not going to create the same strain on our healthcare system as the other waves. Leave you with just one more thing. Next slide. Well, this patient returns worse and has to come into the hospital. Unfortunately, Mr. D did go home, and despite our best efforts and with good intentions, he came back. I thought I had a slide on the Alberta Medical Association patient resources. You can look it up on your time. I'll put it in the chat window, but I think I'm passing the baton to, next slide. Well, this is the patient resource page. Feel free to look it up. It's freely available, and I think a lot of really good education can be found here that we would not almost certainly never have time for in most patient encounters in the emergency department.